Hello. Hello, everyone, and welcome. Oh, this is loud. Welcome. It's my great pleasure to introduce our KITE Research Rounds speaker today, who is our very own Dr. Azadeh Yadollahi. Dr. Yadollahi holds a Canada Research Chair Tier 2 in cardiorespiratory engineering, and she's a senior scientist at KITE and also an associate professor at U of T in the Institute of Biomedical Engineering. She also holds an adjunct faculty position at the University of Manitoba. Dr. Yadollahi is the director of fabric-based research, fiber platform, with the vision to deliver revolutionary textile-based wearables for providing equitable access to healthcare wherever users are. Her research is focused on developing digital technologies to provide equitable access to healthcare for people with cardiorespiratory disorders. At UHN and KITE, she leads the Sleep DB laboratory, which includes state-of-the-art technologies to examine the intricate interplay between body fluid and cardiorespiratory disorders. Dr. Yadollahi is a strong advocate for inclusion, diversity, equity, and accessibility, IDEA for short, and chairs the UHN Research IDEA Committee. Beyond UHN, she leads and co-leads several national initiatives to train the next generation of researchers and innovators to design digital technologies to promote health equity and IDEA. To date, she has published and co-authored more than 80 peer-reviewed manuscripts and presented at over 150 times in scientific conferences, filed 3 patents, and has been invited to give 78 talks on her research at prominent national and international academic institutions. Please join me in a welcome round of applause. Welcome, Dr. Yadollahi.
Thank you so much, Babak, for the introduction, and thank you so much for having me here. So, the talk that I'm going to present today is some of the research that we're doing in development of machine learning models to assess cardiorespiratory function with a focus on sleep apnea. And this is working. Good. So I'm going to have 2 learning objectives. The first one is the application of speech and snoring to assess cardiorespiratory signals. And the other one, if we have time, would be about how to do co-design and co-implementation with end users when we are developing technologies. And feel free to stop me at any time. You don't have to wait until the end. So I'm sure that you're all aware of sleep apnea. And then if not, I'm sure that I bothered you enough with the sleep apnea, or you know someone who is snoring around you, either a bed partner, a friend. And so it's quite a common problem. It's about 10%, 10 to 15% of the population are having a sleep apnea. And the big challenge is that sleep apnea is underdiagnosed in 80% of those with risk of sleep apnea. Sleep apnea has serious consequences, and because it is underdiagnosed, it's a modifiable risk factor and cause of morbidity and mortality. So by better diagnosing, we can have better treatments. One of the very first things that we did, and it might be somewhere here, is that we developed a smart device, a smart wearable device called Patch, as you can see here. I don't know. But basically, it's a small wearable. It has a microphone and a 3D accelerometer. As you can see in the figure, you can put it on the neck. It records respiratory sounds and respiratory-related movement over the suprasternal notch, and then it can diagnose a sleep apnea based on just these 2 sounds, like based on the sounds and then also the movement. And we had 3 patents out of that were licensed to Brazotech, and they got FDA approval last year for commercializing the technology. So a lot of the things I'm going to talk are around this patch, and then how with development of this, we were able to have better assessment of sleep apnea. but also then how that lead to other methods. So one of the things that we've done early on is if someone goes to the sleep, have a sleep apnea, the practice in Ontario for them is to go to a sleep laboratory, have about, okay, we don't have a pointer. Have about 20 sensors attached to them and sleep to diagnose their sleep apnea. And that's why it's quite cumbersome and it's very underdiagnosed. So what we did was basically running clinical trials with our patch at the same time with polysomnography and develop different algorithms to analyze the sound and then also the movement based on the 3D accelerometer and see how good we can use just the patch to diagnose a sleep apnea. In one of the early works, we used the tracheal sound and then also the level of the oxygen in the blood that was recorded with a pulse oximetry. And the reason is that the American Academy of Sleep Medicine only approves devices if they have measures of the oxygen saturation. Otherwise, they don't approve it as a device or FDA. And what we have shown was that what this graph here shows is basically that on the vertical axis, we have sleep apnea severity based on the, our patch, our device, or only the mic, the sound. And the horizontal axis shows the gold standard, the sleep apnea severity based on the full overnight sleep study. And each point is one participant. And as you can see, just using the sound, we were quite able to diagnose a sleep apnea with a very high accuracy. And not only that, a lot of studies have done that, but they just give an overall number and doesn't mean how many miss events they have or extra events or false positive and false negative they have. And what we did was to show that we have high accuracy in finding individual event and even beginning and end of the respiratory events. Then we became a bit more ambitious and said, what if we can do it with less signals? Just look at the movement of the trachea, because it's much easier to record movement of trachea compared to the sound, much lower sampling rate. And then we showed that by doing that and using deep learning models, we were not only able to estimate a sleep apnea severity with a high correlation, but actually the model was even more accurate. One of the other reasons that we're so passionate about recording the sound over the neck is that we're also very close to the jugular vein and then the carotid artery, so we can also collect heart sound with a very good accuracy. So when you put the electrode, the sensor here, not only you get respiratory sound, but you also get heart sound, and then you can use that as an assessment of the cardiac function. And one of the things that quite is important when it comes to the sleep apnea is that the people with the sleep apnea have high risk of hypertension and then cardiovascular condition. And then, but it's not easy to monitor blood pressure. And the only way, like over the night, and the only way that we look at the cardiac function is just look at the ECG. So what we wanted to do is to see that how the heart sounds are changing if there is a respiratory event, if the people stop breathing or having a reduction in respiration that causes an increase in the, over time, increase in blood pressure. And then if that is so different in people who have heart disease to start with versus those who don't. So what we did was that what you can see here, we have the recording of the sound. The gray area is where there is a problem in the breathing. So either the people are stop breathing or having a reduction in their breathing. That pink area is when the brain says, okay, there is no enough oxygen, you need to wake up because I don't get enough oxygen. So it's called arousal. And then we looked at the heart rate and the heart sounds and basically respiratory sounds before and after the event. And we always know that when there is an event like this, when the oxygen level goes down because of a stop in breathing, heart rate increases, there is an increase in sympathetic activity, which is basically increase in the workload of the heart, so that the heart can basically gets more oxygen to the brain and the rest of the body, and that's what contributes to a lot of cardiovascular outcome, all these frequent increases in the cardiac function and reduction in oxygen. What is the challenge? When we are recording the sound with one microphone over trachea, we have a lot of noises. You get respiratory sounds that we like. You get snoring, which is much, much louder than the respiration. And you also get heart sound, which is in a smaller, like lower frequency component. So the first point is that how can we separate these different components of respiratory sounds, the snoring and heart sounds, to get to the heart sounds, and then the first and the second heart sound. And that's what this second graph is showing. So the top graph is electrocardiogram, just as a sense of to know where the R peaks are. The second one is the respiration, like inspiration, expiration, and all those high amplitude red curves are the snoring, which are quite loud. And what you want to get, and the algorithms that we developed for basically separating the signals, gives the first and the second heart sounds that you can see. You can really hear these two. And then we used the recording of the first and the second heart sounds to look at how the heart sound intensity is changing from before to after event and during the event. So the vertical axis shows the intensity of the first heart sounds, S1 and S2. The dark bars are before starting of the event, and then the dark gray is post-termination. And as you can see, with all the events in the people that we looked into, about 80 people, the intensity of the heart sounds was increasing, showing that the heart was working harder post-respiratory event. And this was also associated with more increase in the heart rate. And we also show that this is associated with the amount of drop in their oxygen level. So if with the respiratory event, they have more drop in the level of the oxygen, the intensity of heart sounds is increasing, and this is also associated with changes in blood pressure. So in a way, moving forward, this could be a way to look at potential continuous monitoring of blood pressure based on the sound during sleep. Then we looked into how we can use the respiratory sounds and respiratory-related movement to be able to extract more signals that are important for assessment of the sleep apnea. And the main signal that we look into for basically sleep apnea is the airflow. So the amount of the air that the person gets in and out. And the way that they measure it is they put like cannula inside the nose to look at the pressure differences, or bands on the chest and abdomen to look at respiration. There's also one spot. And there's pizza. We have the, I know, but I have the experts in sleep apnea physiology now in the room, so I really need to make sure that they're nice with me. So that's why the pizza was my bribing them. So what we wanted to do is to see how good we can use the respiratory sound or the movement to estimate airflow. And the idea is very simple. Think of a pipe, like look at your airway as a pipe. If air goes in and out, depends on the intensity of the air, the amount of the airflow, and also the shape of the pipe, the intensity of the sound is changing. And that's what we did. So basically, the top graph shows the airflow from the gold standard. So the positive is inspiration, negative is expiration. The second graph shows the intensity of the sound. So we look at the sound that we are recording, we look at the energy of the sound in a small windows, and as you can see, it's always positive. And then we developed algorithm that based on the shape of this sound energy detects if it's inspiration or expiration, and estimate the last one, which is the estimated airflow just based on the sound. And this is during normal breathing while the person is asleep. What this example shows is, again, another sample of data collected during sleep, but now we have a snoring. So all those high fluctuations in the airflow are the fluctuation of the airway because of a snoring. And even though we have a snoring, we were able to detect or estimate airflow. And you see that now during inspiration, we have some plateau at the top of the airflow. So it's not a nice round shape. It's plateau because of the narrowing of the airway. The amplitude of the air cannot go beyond some level. And that's quite important because that shape can help us to find what the potential site of the collapse in the pharyngeal airway is. Similarly, when someone is having hypopnea, so the level of the air that they're taking in is reduced because of partial collapse of the pharynx, we can see that the last curve that shows the flow collected from or estimated from the sound also shows this relative reduction in the amplitude of the airflow. And finally, when there is the apnea or complete block in the like the pharyngeal airway, and then the airflow is sort of close to zero, the sound energy shows a reduction in the amount of the airflow. So, and that's where the base of everything is, that by looking at the sound energy, we can get an estimate of airflow and estimate the severity of pharyngeal collapse. We have done more models in terms of how the movements of the trachea can be associated to the movement of the chest and abdomen, and gives a better example of the amount of the air that gets in and out. As I mentioned, we also looked at the shape of the signal, because when we look at the energy of the breathing sound, it's always positive. So to be able to know when the person is inhaling and exhaling, we looked at different features from the shape of the sound energy to predict or estimate if the positive that we're looking is inspiration or expiration. And a lot of that was based on that inspiration is usually more symmetrical, round shape, while expiration is more skewed. And we use this algorithm to see how accurately we can estimate inspiration, expiration, and then we tested in different conditions like apneas, hypopneas, when there was a snoring, and we showed that the accuracy was quite, acceptable, knowing that this is raw, the data collected in the real situation. And the delay in detecting the beginning and end of each respiratory phase was around 100 milliseconds. Any questions so far? Yes.
So you said that the data was collected in real-world settings. So was this still conducted in a sleep laboratory, or would the patients wear these patches throughout the day in their actual homes?
So these data were all collected in the sleep lab at the upstairs in the 12th floor, so a clinical sleep lab with all the polysomnography and everything else. More questions? Good. So then we were interested, thank you so much, Tess. We were interested to see that if we can do all of these things based on the respiratory sound, how about if we look at the snoring? Because although it doesn't mean that everyone who snores have a sleep apnea, or everyone with a sleep apnea will snore, but there is a high association between them. And again, why we were interested in the snoring was that, can we look at the snoring as a way of not only detecting if someone has a sleep apnea, but go a bit beyond and look into, can we use the snoring to get more information about the shape of the airway, the pharyngeal airway, or characteristics of the airway. So basically look at the snoring sound as a way of imaging of the airway, knowing that the airway in the most simple way is a pipe. So the length of the pipe, diameter of the pipe, collapsibility of the pipe is going to change the frequency component and the amplitude of the sound that we are collecting. And then a lot of that is coming from the knowledge in the speech production. So we assumed in our model that we have a sort of vibration that is the source of snoring. Either it could be soft palate or the tissue vibrating, so that's our input. Then we have the airway that acts as a filter, and then like the shape of the airway, and change the shape of the pharyngeal airway based on the collapse, and then can we use that to get more information about the airway size. The other way to do that is to do imaging. Like for example, in children, they do MRI during a sleep to see that, okay, what is the site of the collapse, and then do surgery so that they reduce the consequences of the sleep apnea. So we were thinking of this to replace that. So what we have done with the model that we developed, actually we got some very interesting results. So these are from the same population, from overnight recording. One of the things that we have done was we looked at the size of the pharyngeal airway at the beginning of the sleep and at the end of the sleep, and then like in the evening and in the morning. So we had a measure of the amount of narrowing in the pharyngeal airway from evening to the morning. And what we found was that the people who have more narrowing in their airway, so you're looking more toward the left of the first graph at the horizontal axis, the sound intensity is increased, so their snorings are louder, which makes sense. If the pipe is narrower, the sound energy is increasing. So the more narrowing is associated with louder snoring, and even louder snoring more toward the morning than the evening. We also showed that if the length of the airway is different, for example, men and women have different size of the pharyngeal airway or the length. So if those that have longer airway, the formant frequency or the resonance frequency are lower because there's an inverse relationship between the resonance frequency and length of a tube. And we also showed that for the people that get more edema in their neck from evening to the morning, so we measured that, so there's more damping of the sound as it goes from of the snoring sound, and then the intensity or the frequency components are changing. So that was our first attempt on how we can really look at the snorings as a way of imaging of the airway and get more information about the physiology of the airway. We also looked into that, how the snoring can help us to predict response to the treatment. So one of the common methods for sleep apnea treatment is the people are wearing CPAP, applies pressure with positive air and keep the airways open. But there are a good number of the people that are not compliant to CPAP. They don't like to wear something, and they use oral appliances for sleep apnea treatment, especially in those with moderate and mild sleep apnea. And the two common ones, one is called mandibular advancement device. It's like something like a mouth guard that they put into the mouth. And it's like an basically oral appliance. It slowly moves the jaw forward, so the jaw comes forward, so there is more room in the pharynx, and then opens up the airway to reduce the sleep apnea. And the other one that's called tongue stabilizer device is Azadeh, as you can see it. I don't know who is using it, but basically it keeps the tongue in place not to go back, because tongue is the main muscle that closes the airway. So this is the data collected from one of our colleagues in University of British Columbia. They collected data from about 38 people who went through mandibular advancement, and then about 12 people who used the tongue stabilizer, and they grouped the participants into responders and non-responders. Responders are those that their AHI reduced by more than 50% after the treatment. And then at the same time, they collected a snoring with a device built into the device, like a small microphone, but it's a very low sampling rate. And that was one of the challenges that we had. So what we have done, so this is basically how the data was collected. The people did overnight sleep studies. The snore data was, as I said, the sampling rate was quite low, below around 100 hertz. And then what we have done was to develop algorithms to extract features from the snoring signal, and then use a live and out subject to see if we can classify participants into responders and non-responders to this treatment. And the reason that it's important is that it's not easy to know who will respond to this treatment. The mandibular advancement is expensive. It's about a couple $1,000, and it takes about 6 months to move the jaw slowly forward. They can't do it. You need a dentist to do it like the personal, basically for every individual, make the individualized oral appliance. And then if it doesn't work after 6 months, it's a lot of money and challenge for the participant, for the patient. And what we found was basically to look at all the acoustic features, and we did it in two types of analysis. The first one was that if you look at the data both pre and post-treatment, are there features that are different between the two groups of responders and non-responders? And that's when we look at both pre and post-titration. And the second one is and that's the main application, if we just have the pre-titration, can we predict responders versus non-responders? And what we found was overall, we found a very high accuracy in predicting responders versus non-responders. Our algorithms are overfitting for tongue stabilizer because we have a very small sample size. But the results are promising. The accuracy is in the range of 70% to know who will respond to the treatment in this small sample size. And then when we compared our methods to the other ways to know if someone is responding to the treatment, our accuracy was comparable or better than the previous studies, that some of them are actually invasive imaging methods. Any question before?
Explain what are the features that are used in your classifier? What is the most important predictor or predictors?
So here are the features that were selected more importantly. So a lot of them are showing, basically, if you look at the power spectral density of the sound, like the snoring, looking at the entropy of that, like the mel frequency capstone, are still some of the very good features that we have. We also have the kurtosis skewness of the power spectral density were among the good features that we had. So these are traditional, old-fashioned features based on the sound.
Looking at the variability of snoring sound, right?
We look at the variability, but these are also showing variability or the shape of the power spectral density. And again, as I said, a challenge of this one is that the data was collected with very low sampling rate because that was not the outcome. This was like the main thing. So it was a retrospective study to look at. So given how all of these were working and the snoring was so exciting and then can show some association with the shape of the airway, we became more interested that can we look at the speech and then so that we can predict the risk of a sleep apnea based on the speech and the vowel articulation. Why we think that it works is that, as I said, the main muscle that contributes to the sleep apnea and collapsing of the airway or keeping it open is tongue. We have all these other muscles, but the main muscle is actually tongue. And then when we're saying different vowels, we're using the tongue to move inside the, in the mouth and then changing the shape of the pharynx. For example, when you say a vowel like E, like this one, when you say E, the tongue is coming forward and up, so the airway at the back is the most open. If you say A, the tongue is going all the way back and down, so the airway is the narrowest. If you say like oo, then the epiglottis is the smallest. So that's the whole thing and the idea. Why it's so beautiful is that you can do a lot of these assessments while someone is awake, and not only get a measure of the shape of the airway, but even some features of the tongue, like how collapsible it is. So that was our hypothesis. And this again shows that how with different vowel articulation, these are well known in the speech production, the shape of the tongue is changing, the formant frequencies are changing, and that's why the resonance frequencies are among the main features when we look into the speech-based sleep apnea assessment. So one of the things that we did early on was to say that we need to have a way of showing that, yes, with the vowels, actually the size of the airway is changing. So we need some imaging as our gold standard. We couldn't use MRI because it's too expensive. So we developed our protocol based on ultrasound to be able to assess the shape of the airway. The ultrasound is not working because it doesn't work with air. So if you just put the ultrasound, you get a lot of black, dark image. So what we did was to develop this protocol to actually look at two sides, like two intersections of the base of the tongue, so that we can get the two cross-section of the airway, and then by assuming that it's a rectangle, get an area of the airway. And here you see an example that, for example, when someone says E, what we're getting from the ultrasound, the size of the airway, the length in one dimension, the parasagittal is increasing. When someone says the length in that anterior posterior is decreasing. So that's what we did. We look at these two dimensions from the ultrasound images, and what we did, and then we also did acoustic pharyngometry, which is another method that you can get the size of the airway, but not when the people are talking. And what we found in the first graph, it shows that, yes, the diameter we're getting from the ultrasound has a high correlation with the size of the airway in the static. When the people are saying different vowels, like E, A, U, the size of the diameter or posterior anterior diameter is actually reducing from E to A, and it is different in those with high risk of sleep apnea. So the size of the airway based on the ultrasound is less in people with high risk of sleep apnea. So then we use that to look at, now that we have our gold, sort of our established gold standard based on ultrasound, how good we can predict it based on the sound features. So the blue lines are showing data in people with low risk of sleep apnea, and the red ones are people with high risk of sleep apnea. So what is interesting is that not only that the diameter is smaller in those with high risk of sleep apnea when they say E or A, but interesting, the change from E, or the most open, to the most closed is more in people with low risk of sleep apnea. So if the people are having risk of sleep apnea or high risk of sleep apnea, the tongue cannot move that much, or the airway size doesn't move that much. It's either because the tongue is already big and the airway is small, so there's not that much of room to maneuver and change the shape, or it's just that the tongue is stiffer. And these are also proven by MRI imaging, that the range of the variation of the tongue and the airway is less in people with more severe sleep apnea. We then also use different classifiers to look at just the acoustic features of the sounds, like A, E, and then estimate the length of or diameter of the airway, and then the correlation was 0.7. So all of these together shows that, yes, we could use sounds or speech as a way of assessing the shape of the airway. There are other things, like I'm sure that some of you might have seen that voice is now becoming more and more in everything. Like this is another study that they use voice to predict people with hypertension. And then they showed that they have very good accuracy to predict people with high blood pressure based on their speech. We did a systematic review of different methods available in the literature of using speech for assessing the risk of sleep apnea. And then in general, the results are promising. The accuracy of the methods is in the range of 80%. What the challenge is that a lot of these studies are in small samples in a specific group of population, like Spanish speakers or Hebrew speakers, and not really generalizable. And then the way that they assess their method based on the sleep apnea severity is not, you can generalize from one study to the other. So while there is, just going to go quickly over this. So while there is a lot of potentials of using the sound, there are some big challenges to address if we want to have methods that we can use as in the general population. We need to have larger data sets with sound that incorporates people with different, like both men and women, people with different ethnicity, people with different age, because the sounds are going to be different based on the age. It's important to make sure that the data is not always just recorded in a very controlled setting. How does it work if it's collected in the general like setting with all the background noises? And then how interpretable the data is. If we just give it in and out without that much like as a black box to the AI model may not be really applicable to the physician, that what does it coming? And how we can use that to get more information from the physiology of the airway. I give some examples like the size of the airway, potentially where the collapse in the airway is happening. And that's some of the work that we are doing at the moment. So we are collaborating with different sites in US and Canada. And what we are trying to do is, can we use speech as an accessible method to diagnose the risk of sleep apnea and potentially the site of the collapse, that where the air, because if we know where the airway collapses, like which part of the tongue is the source of the collapse, then the treatment can be different. So we are working with the sleep clinics across Toronto, and then we're collecting data in the community. We are working with University of Michigan because they have data in a different population, but also in people with and without a stroke. And then also with people that are having more chronic conditions, for example, people from the shelters that have multiple chronic conditions. They may also use substance, so there would be, or have higher stress, so the physiology could be different. And then what we are doing, our protocol is we do a sleep study, and then before the sleep, we ask the people to say different vowels while they're sitting and standing, and then we take picture or images and sound in the profile, and then also on the side, because we're also looking at the image. And then, so these are some preliminary results in 35 people, and about half of them had a sleep apnea. And what we found was that there were some acoustic features, like in different frequency bands, that were significantly different between those with and without without a sleep apnea. So here the red is data from those without the sleep apnea, and blue is those with the sleep apnea. And here the full polysomnography is the reference for a sleep apnea. And then we found that there were features from both different vowels that were important in were different between these two. We found the features that were more important, and then, as I said, a lot of those were in different frequency bands. And then we developed algorithm to extract the features, then use classifier based on the method that we use every subject as for training and one subject out for classifying. And what we found so far was that with the model that we have in this limited data, we have an accuracy of about 85% to just use the vowels and features from the vowels to predict the risk of a sleep apnea. Our results improved because now we have more data from different sites, and we can also have similar accuracy of 80% in those with a stroke and without a stroke. That's some of the results we got just recently. And then we also try to improve it to use more advanced models like deep neural networks to extract features and then try to see if we can improve our models. We are still working on that one. We're trying to look at different elements of the frequency components of the signal, both in the amplitude domain, but also in the phase. And so far, what we found was that when we look at all these features together, the sensitivity or the accuracy is around 70%, which is potentially because our sample size is small to develop this algorithm. Here we just use data of 35 people, but that could give us better, hopefully better results with more data. And I want to thank all the people that were involved in these studies here and also in US.
If there are any questions, please raise your hand. And you can handle questions all out.
Thank you so much for your presentation. I have a couple of questions. One is that, did you evaluate the sleep apnea and snoring in different positions like side lying and supine positions? And is the risk different in these positions? This is the first question that I have. And also, they say that the best angle is 30 degrees when you want to have the airways open. So could you please just comment on the best angle and the pillow height, let's say, for those people who are getting these risks?
So Barry and Vanessa are much more expert to answer that question here, but yes, there is an association between the position and then the sleep apnea, and that's what's called positional sleep apnea. And the whole thing is because of gravity. It's the gravity that pulls the tongue back and then collapses the airway in the pharynx. So if you lie in supine, that's usually the worst condition or the more severe sleep apnea and the snoring. And if someone sleeps on their side, like left or right, because the gravity doesn't pull the tongue back, the chance of collapse is less. So one line of sort of treatment, especially in mild cases, usually to tell the people to sleep on their side, especially if they have more events during the supine. And that's one of the things that comes from the sleep study, that in one position they have more events. Sleeping with the head tilted up usually helps because it also increases the lung volume. Because the effect of the gravity on the tissues in the abdomen, and then that can push up and then reduce the size of the lung and make breathing harder would be less. So in general, sleeping with the head raised is helping with the sleep apnea, especially in people who have heart disease or lung disease, that they have edema or fluid in their lung. What is the optimum angle? I don't know. But one thing that might be even more important than the angle is the angle of the neck. So the position of the neck. So if the neck is a bit tilted, might be more effective than if the neck is there like this. So you may have a tilt. And that's sometimes a problem with multiple pillows, that if they make the person to become like their head down, may even make worse.
So thank you for your comments. And so did you evaluate the same angle for every participant that you had?
No. And because it was like, we do have those angles, but we didn't look at the impact of that. That's a great point. We just looked at the overall. But in many studies, we look in general if it's in the side or supine.
Thank you.
Is it possible to do tongue exercises to reduce the risk?
Yes. So there's a lot of groups that are actually working on that. So if you go to YouTube, there is a group in Brazil that are so famous of doing these tongue exercises, and they say how to do that. The idea is that you have to move your tongue up and then push the ceiling of your mouth like like this, and then do that I don't know how many times a day. So they do a lot of that, and they did the studies how effective it is. I don't know how effective it is. If you talk to Katrina, she says it's not. If you talk to some people, they say it's very effective. There are some devices that they put something in the mouth that don't let the tongue to move backward. I think the most effective one that I've heard is if you play didgeridoo, the Australian instrument. It's not necessarily the improving, like exercising the tongue, but just the level of the way of the breathing and the practice. Actually, that improves the sleep apnea a lot. So you can do that. There are studies on didgeridoo, and it looks cool. But there are devices in the market now that are doing. There is beside all these exercises that are a bit tough to do, there is a device that came about 4 or 5 years ago, that what they do is like a small device that is basically, you put on your tongue, they say that during the day for 20 minutes, it applies electrical stimulation to the tongue to activate the tongue muscle, and they claim that it improves sleep apnea or mild snoring. I don't know how much, but then I really don't know. They say, and it costs about $1,000. And I don't know how many people are really doing 20 minutes of exercise, because there are all these other types of exercise that we don't do. And I don't know. So there are other devices. I mean, there are invasive devices that basically like the pacemaker for sleep apnea that they implant, and then there are like go around the nerves, like two cuffs going around the two main nerves that comes to the tongue and activate the tongue to prevent the sleep apnea. They have done a lot of work to say who is responding to that, and now they have really high sort of response rate. It costs about $40,000 US, and it's not, I think that's the number for the surgery. Is it 30? Okay. It's a bit less, it's 30, so maybe you can do that. But it's not covered here in Canada. And then there are other methods of stimulation of the tongue are coming, but these are the two that I know.
Just a quick thing. With the tongue size, which I don't think you covered that much. I was late, sorry, but in terms of tongue size, it plays a big role in how much sleep apnea progresses during the night. One of the things about sleep apnea and the tongue is that there's little control you have over it, regardless of how many exercises you do. Muscle tone drops tremendously, especially in REM sleep, which things get worse. Supine position makes it even 10 times worse. And regardless of pillows you use to prop yourself up, there's a dynamic in sleep that you can't fight, which why the gold standard for treatment, it tends to be airflow from CPAP, or sometimes the mandibular devices will help, but it also goes to the fact of the person's oral cavity, how it's designed by nature. But one thing I wanted to follow up on was with neck size and the fluid shift. So fluid shift and neck size, if that was taken into account when you're doing your assessment, and oximetry. So you can have the sleep apnea, and it can progress at night from snoring sounds and generate a certain profile, but was oximetry measured or taken into account for your assessment?
Those are excellent comments. So the comments that Barry gave in terms of the physiology of sleep apnea and the role of different parameters, I mean, I could have never said better than that. Thank you very much, Barry, for that. And that's why you need experts in the room. And that's why I was offering pizza. In terms of the oximetry, in one of the studies that we did, we actually look into the pulse oximetry and then how that could add to the accuracy of our methods for diagnosing sleep apnea. But we also showed that if it's just sleep apnea severity, the correlation is still good even if you don't look at the pulse oximetry, because in general, you will have a drop in the oximetry if there is an apnea or hypopnea. It may not be one by one based on the ASM criteria, but usually you have that. 4%. Exactly. That's a great point that we didn't look into yet, that what happens, it depends on how the sounds may change based on the amount of drop. We did look into like how the snorings and the features are changing from the beginning to the end of hypopnea, assuming that as you progress, like breath by breath in the collapse, as it goes toward the end of the event, you have more narrowing, and then the frequency response is increasing and changing because you have more narrowing just before the person wakes up or arousal. So we did look into those ones, but not in depth. Thank you.
Just one question. So I've seen the chart wherein there's a BMI. So how significant is the BMI when you're doing an assessment with all of those devices? So was there like an improvement when I don't know, with how you had like a sort of like a cohort or a group wherein you did like a study wherein they have decreased their weight in terms of the BMI? So was there anything that was done then?
So definitely reducing weight improves the sleep apnea. So that's one of the things. It's not one-to-one association, but that's a risk factor. And then there are recent studies showing that maybe something that is more important than BMI is the neck size, like local, or the waist size. So the ratio of the waist to hip is more important than the overall BMI, because if there is more fat around the abdomen, that is the one that is pushing basically to the lung and contribute. So, and then there are also other studies showing that the amount of the fat in the tongue is also contributing, that may be more important than the overall BMI. So definitely weight loss is helpful for so many different reasons, but it also matters where the extra weight is. Any other questions?
Okay, so we have a question from the chat. This person says, thanks, Azadeh, for presenting your amazing work. How do you think fluid overload, heart failure, or CKD would interfere with a I can't pronounce this word.
Do you want me to read it? Which one is that? Okay. So the question is, how do you think that fluid overload, for example, in people with heart failure or chronic kidney disease, would interfere with the tracheal sound? It would improve or disturb the collection of the sound. So that's a great point. People who have heart disease, heart failure, or chronic kidney disease usually have extra fluid in the body, including in the neck. So one of the things that we showed was that not in people with heart failure, but when there is overnight, there is an increase in the edema around the neck, the intensity of the sound is decreasing, because now it's like that extra fluid is acting as a low-pass filter. So definitely it is changing the sound features, and that is actually an interesting thing to look into. We looked in the past of just looking at the breathing sound to predict the amount of fluid and edema in the neck. So there's a lot more room to do, and definitely the sound features are different, but we haven't done to say beyond that, yes, the sound definitely will be dampened, but I don't know about what else can happen.
Great, thank you. Does anyone else have any questions? Okay.
Thank you very much.